my pleasure to welcome you to this keynote session. We are really delighted to have Dr. Rick Altice, who said that I didn't need to introduce him, just to tell you all he's a good guy, but you really all know that. So I'm going to really introduce him a little bit. He's professor of medicine, epidemiology, and public health at Yale, and he serves as the director of clinical and community research, the director of the community healthcare van, and HIV in prisons program. He is a clinician who is board certified both in infectious diseases and addiction medicine, and really works across the globe as a researcher looking at the interface between infectious diseases and substance use disorders. In recent years, he has increasingly become involved in implementation science to find ways to really disseminate research and evidence-based practices. And, you know, I'm particularly delighted. He's a good friend. He's also a collaborator for some of the programs we have in West Virginia. And he's going to speak to us today on bending the curve on the opioid epidemic in rural settings, strategies, and potential solutions. Rick?
Great. Sally, thank you so much for that kind offer. And hello, everybody, in this very strange virtual world. It's a pleasure to sort of think a little bit about the opioid epidemic and its impact on rural settings. And over the last couple of years, we've been increasingly working across 5 states that are primarily rural on sort of co-managing opioid use disorder and infectious diseases. So I'm going to take some of the sort of the lessons that I've learned along the way and sort of build it into a framework about sort of thinking about this a little bit more comprehensively. These are my disclosures with regards to grants, speaking bureaus, and consulting, and I have no stocks. And then I have a number of NIH grants and other grants that are really quite related to some of the content that I'm going to be going through today. So if I can just sort of walk it through, these are the sorts of things that almost everybody here is going to know, is just this great disparity between sort of the geography. 97% of the US is geographically rural, yet only 20% of the population resides there. But there's this huge disconnect with an incredibly higher burden of disease and lower life expectancy. And relative to non-rural communities, people in rural communities are more likely to die from a host of things, but one among them that has gotten a lot of national attention over the last few years is this category of unintentional injuries, which is sort of a larger umbrella for overdose. And within these settings, sort of the issues for people of color are exponentially heightened as well. So we've got a lot of these sorts of things that are coming together. There's a recent report that came out on the barriers to health equity in rural settings. And I really like this word cloud because it really starts to get at the things that were the most important from this group meeting where people brought up a number of terms. And while a lot of these things are going to be incredible barriers for dealing with any kind of health problem, but specifically with opioids, I do want to say something that there are some things that are going to be very useful that we can look at, such as how do we think about utilizing federally qualified health centers in primary care? How do we come up with pilot programs, maybe implementing types of programs that might help? Gosh, what we've learned from COVID and what we're doing right now, the use of telehealth and related to that, teleeducation through things like Project Echo, issues to overcome and improve access to care, maybe through these telehealth areas, ways to remotely monitor patients for their disease. Certainly with COVID, I manage a large number of patients remotely by sort of pulse oximeters, et cetera. And then, of course, one of the issues is where you can use these sorts of tools, there may be issues around inadequate broadband access. And I know that in some of the work that I've done in Appalachia, there are these hollers, these areas that are really quite remote, where you may not be able to get access, and it may require a rethinking a little bit in terms of how you sort of carry some of these things forward. So let me first of all set the stage. and talk about the opioid epidemic, that we do have. And so this has been sort of percolating along, but the epidemic has been in about 3 waves. The first wave is really prescription opioids that sort of came to our attention. That was associated with a fair amount of overdose and death. There was essentially some time where there was a transition to heroin use. It's biologically much more available. And then as clinicians began to shut off the access to prescription painkillers, people transitioned as a way to sort of maintain their dependence. And then in the more recent wave, we have begun to see an increasing amount of stimulants. And on the East Coast, those stimulants are mostly cocaine. In the Mid-America and the West Coast, a little bit more of the methamphetamine, all of which sort of complicates treatment and managing overdose, as it has its elevated risk of death as well. And then, of course, really quite dangerously and recently has been the influx of synthetic opioids like fentanyl, carfentanil, and other synthetic derivatives that are majorly more potent than heroin, which sort of increases the susceptibility for overdose. So let me just sort of walk through. One of the things is that this epidemic of opioids is certainly not uniform. It varies really quite dramatically from state to state, but even within counties. So, it's all health is local, and that is indeed what is going on here. But there is indeed a disproportionate impact on rural areas where there seems to be an uneven distribution of resources. Just to sort of paint that a little bit further, these are some of the changes in non-fatal overdoses over the course of the last year or so. And you can see that there are certain areas that are disproportionately impacted. The areas in gray don't have data reported, but I will say that if you sort of look across this swath, with the exception of Vermont and New Hampshire, you see this mid-Atlantic all the way up through the New England, where there is this incredible opioid epidemic where the burden on rural communities is markedly increased, and it's uneven relative to the rest of the country. So what are some of the features that we have to think about with regard to dealing with the opioid epidemic in rural settings? The large distances that people have to travel. A really elegant study looking at geolocation by Paul Jodry here at Yale looked at the sort of the distances that people have to travel for dialysis and for other sorts of things. And for addiction treatment, it was really quite dramatically further than it was for almost any other kind of service. There are few transportation options. Public transportation seldom exists in these settings, and so people often rely on family members or friends to get them to places here and there. And there have also been some unequal issues around insurance, some of which has gotten better as the Medicaid expansion has improved. I would also say that there is a structural impediment that is especially heightened with the opioid epidemic that is different than things like dialysis or these other kinds of services. And that is the sort of distrust that has developed between people who inject drugs, the law, healthcare providers themselves, and community leaders, this sort of what I call generalized stigma. And with that has certainly turned out to be some level of discrimination with regard to withholding treatment or feeling as though people are undeserving of treatment for a chronic relapsing condition. There's also been limited infrastructure for medications for opioid use disorder. If you happen to go to an urban place in the Northeast, we probably have 3 or 4 methadone programs that are really quite active. But those kinds of services are really much more challenging, and they're much more stringent to provide services, making them methadone sort of much less accessible in these kinds of settings, and relying on buprenorphine as the primary care. But also syringe services are unequal in terms of their availability, as well as clinical services for HIV. And all of this sort of belies the fact that these epidemics of opioids and HIV and Hep C are really quite intertwined, and we only have to look to the sort of the first national spotlight in Scott County, Indiana, to see that the two are related, but we have seen numerous outbreaks across a number of settings, and they are primarily in rural settings. So the ending the opioid epidemic in the US has 4 pillars. I wish I could have drawn a Greek temple here to sort of show this, but we have first among them to prevent the misuse and addiction. And so if you sort of think about how you might sort of stratify this, the prevention of misuse and addiction happens very early on, but it also has to do with issues around interdiction, that is cutting off the supply. So this is a supply and a demand phenomenon. And then putting in place sort of limited prescription in emergency departments, not prescribing larger amounts, our prescription drug monitoring programs, et cetera. The second pillar is really to reduce overdose death and harmful consequences. So this is really what I call the tip of the iceberg, the most severe consequence of the opioid use disorder. And we have a number of tools in our toolkit, but they're not really scaled to need. So we have opioid overdose education and naloxone distribution, medications for opioid use disorder, and then of course, other issues to reduce the likelihood of transmission of HIV or Hep C. And as part of this, we really need to sort of improve our addiction treatment. And as much as I would like to say that our medications are really quite good, it is our delivery system that has failed us. And we have to sort of really have a Manhattan Project to rethink what we're doing. And I'm going to come back to the topic of Touchpoints. That is all of the places where you can potentially interact with a person who may be at risk for complications of opioid use disorder. And then of course, key among our addiction treatment is medications for opioid use disorder. I know that there is going to be some discussion probably later on, but I'm going to sort of make the point right up front that medications for opioid use disorder are the single most important tool that we have in our toolkit to prevent overdose, but also to re-engage patients back into society and help them towards recovery. And then of course, the final frontier, for those of you who are Star Trek fans, is how do we actually intervene in our criminal justice system? We certainly know that people with opioid use disorder are more likely to be concentrated in our criminal justice setting, whether it's within the courts, whether it's within our jails, within our prisons, and a huge proportion of the 2.2 million people in this country with opioid use disorder pass through one of these settings per year, making them incredibly important places to actually intervene. But as I said before, it is the last frontier, and it has been a slow place to budge with regard to accessing the kinds of services that we need. So let's take a look at our nation's report card. In the opioid epidemic, guidance came out about 5 years ago. So what have we done over the last year or few years or so? Well, we have actually succeeded in reducing the amount of opioid prescriptions. There were 250 or so million prescriptions in 2014. That's been reduced by close to 40% from 2019. And that, I think, is a sort of a major part in the supply element of opioids into the community. We've also done a reasonable job at distributing naloxone and providing overdose education. And that has gone up really quite markedly to well over 1 million. One of the problems has been that this type of overdose prevention is very unequal, with a much larger concentration that occurs in urban rather than in rural types of settings, really making us think differently about perhaps an Amazon type of model that we can use to get these kinds of services into people's hands. This is especially true in settings where there are not harm reduction programs that can actually deliver and distribute naloxone. We have had a sort of an increase in the use of our prescription drug monitoring programs. We're not at 100%, but in many states, they have requirements before you prescribe that you check and you have to confirm that. And that is really a marked improvement. And I think that in part has resulted in the decrease in opioid prescriptions because people look, but they also think. And one of the things that I often think about is the squeeze worth the juice? And there have just been hundreds of thousands of physicians who have been involved in medical education and courses on substance use disorders and all of these sorts of things. But the question is does it translate to patients actually getting access to treatment? So those trainings have resulted in over 85,000 physicians and other licensed professionals becoming certified to prescribe buprenorphine in office-based settings. So that's a marked increase just in the last couple of years. But what has not really happened is our sort of coverage for medications for opioid use disorder has remained stubbornly at about the 11% mark. And so there's a big disconnect between people actually going through the licensing process and then actually putting pen to paper or finger to keyboard and prescribing the medications. So let's just talk about some of the successes, but also the failures with this sort of dealing with a supply issue. This is a very elegant study by Pitt from the modeling group in Stanford, Margaret Brandeau and Doug Owen. And what they did was they said, all right, we've got this sort of this national model of things that we're supposed to do. And they listed a number of different policy strategies. And some of them have to do with sort of reducing the amount of medication for pain prescribing, using the prescription drug monitoring program, using naloxone syringe exchange services programs to prevent HIV, with or without opioid education or overdose education and naloxone distribution, medications for opioid use disorder and psychosocial treatment, et cetera. And one of the things that you see based upon their modeling is that those types of things that are really about dealing with a supply issue, in general, they have resulted, and I'll show you some proof of concept, but our modeling study bears out that it actually increases the total amount of opioid-related deaths. And part of this is because that the minute that you really work on the supply issue first, and this is what's happened in the US, is that is where people said, we can make a difference because the other stuff is so much harder to do. So they shut off the supply. And unfortunately, what that resulted in was a huge amount of transition to injectable opioids and subsequent death as it related to that. There are some things that can actually reduce the amount of opioid-related deaths, naloxone availability and distribution, but how do we create some sort of equity around getting it to rural and non-rural areas? Syringe services programs that are often not available, and when they are, they're just available perhaps maybe a few hours per week. Some of the work that I've done in Kentucky shows that they're available in many counties, but they are limited. And then I would say that the area where you're going to probably have the most bang for your buck is getting adequate coverage for medication-assisted therapies. And even if you just want to not use overdose as your outcome, in general, medications for opioid use disorder reduce the likelihood of overdose-related deaths by about 3.5-fold. So that's a fairly huge reduction in doing that. It also, for people with HIV or Hep C, results in them being more likely to get onto treatment and to succeed with treatment. And it also is the only one among those which is going to have an impact on social functioning, workforce engagement, criminal activity, et cetera. So that is yet another way to sort of reduce the influx, if you will, into our criminal justice system. So we have been successful in making some action with regard to cutting back opioid prescribing. In 2012 in New York, prescriptions were reduced by 75%, really remarkable. So it reduced the number of multiple prescribers. They used the PDMP, et cetera. In Florida, there was a reduction of 50%. And in Tennessee, there was an increase in 36%. But at the same time, there was essentially, as they cut off the supply, there was an increase in deaths. So it did not result in a direct effect on opioid-related deaths, where it increased across the board in all of these settings, and that is somewhat reflected in Pitt's analysis. Let's move forward to reductions in opioid-related deaths and other harmful consequences with regard to our treatment. One of the things that I think that we have to sort of really do differently, and that is to think about touch points. So if you're a great hunter, where do you go? You go to the watering hole where people congregate. And these are places where you're likely to find people with opioid use disorder. So your harm reduction programs, syringe services programs, et cetera, that is a really broad-based community outreach sort of program. And you're likely to engage with large numbers as long as it is not illegal and it's not in a stigmatized setting. Our criminal justice systems are, at least in my state alone, 51% of all of the fatal overdoses last year here, among the 1,700 or so, occurred in people recently released from prison. But we could also think about this through using some community policing models, working with the court and the drug systems, even the prosecutors, the jails, and the prisons. And so these are all potential touch points. And I won't spend a lot of time going through the criminal justice system, but to say it is complex. We've got probation, we've got parole. There are policies in place where if you're on probation or parole, it's not legal for you to receive medications for opioid use disorder. And so we have to really also rethink some of the structural issues to make it more accessible to our patients. Our outpatient clinics, whether they're federally qualified health centers, primary cares, and drug treatment programs, in our rural settings, there is less likelihood that there will be a dedicated drug treatment program or even a behavioral health program. They are often embedded within federally qualified health centers or other kinds of primary care clinics or even rural health clinics that can be available. And we have to sort of think about leveraging things within our system to sort of build up that infrastructure. We also have to think about our sort of emergency responses, that is our first responders. Not everybody who experiences an overdose does go to the emergency department, but once you're in the emergency department, you could either go back to the community, you could become hospitalized, and then of course, without adequate treatment, it does result in fatal overdose at that point. Each and every one of these are places that we really have to think about sort of getting out our overdose education and naloxone distribution, whether it's the police handing them out. We have some excellent community-based programs, but they're mostly in urban settings where this kind of distribution occurs there. But it also can be a conduit for medications for opioid use disorder. And one of the projects that we're looking at now is how do we take our first responders and work on a strategy for a person who is found down in the field. They're perhaps resuscitated, but to try to get a dose of medication for opioid use disorder in them before they ever make it to the emergency room. And so this is really sort of changing the way that we do things. And you sort of have to have an emergency department physician who takes these calls, who is willing to do this. And so this is some of the work to sort of move and reduce the time, because probably 40% or so of people who have an overdose do not make it to the emergency room. So we do have to think, in our community, it's just 25%, but there is a range. And if you do have a large number of people who are not quite making it into the emergency department, you have to sort of roll the intervention point, the touch point, a bit earlier. Essentially, we have 1 in 9 people, or 11% of the people who need medications for opioid use disorder getting it. The greatest need is in the darker colors here. And as you can see, the area sort of through the central of the country, down in Texas, out in the Northwest, are all major areas, but there are also some of these areas where there's insufficient availability. And almost all of these places are places that really do not have urban settings where there's a fairly good infrastructure. The other sort of challenge is that the distribution of the prescribers, that is the only people who can get this medication into people's bodies, and opioid deaths, there is a disconnect. And this is a really elegant study from last year by Hafege that looked at essentially over 3,000 counties. 23% of them were high mortality counties. And within these high mortality rates, they could either have high or low coverage for medications for opioid use disorder prescribers. 71% of these had no prescriber whatsoever, where there was high levels of death. And as you can see that the yellows and the reds are places just where there is a lot of death. What I would call the trifecta would be being in a rural area, having low coverage by a provider, and having high opioid-related death would be a serious problem. And you can see it's that same corridor that I drew earlier on. And where you have the yellow area, it means you've got pretty good coverage by the providers, but they're there, but they're not getting adequate coverage. And it also may reflect in part the timing of the introduction of fentanyl or these synthetic opioids as it relates to opioid-related death. What you do see when you look at this sort of national probabilistic sample is that there are a couple of key features that are associated with being in one of these high-risk counties where opioid death is there high. So if you have fewer primary care clinicians, even in that area, so this is a healthcare shortage, if there's a high rate of unemployment within that community, if you have higher opioid prescriptions, basically the supply and demand issue, once again, in these non-metro settings, this micropolitan setting, which is a relatively new term for me. And then there are, as I pointed out before, there are some geographic areas along that corridor in the Northeast, but also in the South Atlantic that are independent areas where we might need to focus some of our work, but where much of that has happened has been, really across settings that have a higher proportion of rural disease. Let me just sort of talk you through a little bit of what I call that great disconnect that I introduced a little bit earlier. So you can take a place like West Virginia, and I look across here, and on the left, you see the issues around workforce. So facilities, these are facilities that provide medication assisted treatments. And as you can see that the southern part of the state has got the highest vulnerability to opioids. But you also see a huge number of providers who can prescribe. The problem is that the translation to prescription is a disconnect. So even on a micro level, you can see this happening. And the southern part of West Virginia, although the largest city in the entire state is about 50,000 people, this is mostly a relatively rural setting, and it's even more so in the southern part of West Virginia, where I might add was where I was born. There are ways to sort of think about overcoming some of these obstacles in these rural settings. Project ECHO, I think, has met with some limited but really important success in these settings. These are places where you can use a teleeducation model. For those of you who are on this call, I'm sure that you are all familiar with it. The real challenges with whether you're dealing with the opioid use disorder or the related conditions like HIV and hepatitis C, all of which are syndemic with each other, is that through this connection, it's like the prescription, you need to get providers who are sitting on this call. And so you may have a coalition of the willing who do this, but let's say you have a healthcare center and you've got 10 prescribers in that setting and only one person is listening on these calls. It is not really creating a sort of an inequality around the prescription so that there can be adequate coverage over the course of these treatments. I also will say that it's often thought that throwing money at the problem is a solution. And here's an example of 3 states that are next door to each other. You see that the amount of money in Ohio in the north and in Kentucky is significantly higher than in West Virginia, just based upon the shading level. But one of the things that you see is that when you look at the per capita amount of money that's going towards opioid addiction, and this is just one example. I just took the SOAR grants over there. It's really as high as almost 2 to 3 times higher in some of these sorts of places. But it's still, once again, West Virginia has got the highest opioid-related mortality in the country. And part of it has to do with the way that the SOAR money is distributed. And I will speak more to that in terms of the way that people perceive what treatment is in these settings. And so sort of moving towards the concerns around really engaging and at least taking the bull by the horns right from the very beginning is if you do have somebody who survives an overdose, it is really the place where you just can't let go. So I sort of say you need to be a bulldog with sort of velvet teeth. These are people that you need to engage with. And these are 3 very elegant studies. One that was just recently published in Western Pennsylvania on 16 hospitals. And they sort of looked at the recurrent opioid overdose in this group of 4,000 patients or so. And they found about 1 out of 6 would overdose within the next, would have a recurrent fatal overdose within the next year. And of those, about 1/3 of them would happen soon after the first one. So once again, it's an important place to intervene and not make a referral. It means get medication into them right away. They did find some interesting things that were associated with the recurrent overdose. One of them is having an alcohol use disorder or other substance use disorder, a psychiatric diagnosis. Men were slightly more likely to have a recurrent disease. And it was protective if they, rather than just go to the emergency room, they actually got hospitalized. So was it a sort of a change in perception? And then also whether they had received a recent opioid, which was indicative that they were on some kind of pain type of medication and they were being managed in a more organized sort of way. In a fairly large sample, that was from the group in Columbia, but it's a nationwide sample of Medicaid patients. So it's only looking at patients who've gotten through the access issue of being able to have insurance. They looked at a repeat overdose within 6 months, and that was really quite elevated, and also a much higher likelihood of having a fatal overdose within that 6 months. And there were a couple of factors that they looked at, and they integrated multiple databases in order to come up with this, including pharmacy databases. And if they had been prescribed a benzodiazepine, they were 71% more likely to have a fatal overdose. If they were using heroin rather than prescription painkillers, they were 57% more likely. And if they had required mechanical ventilation at their first admission, they were much higher to have a fatal overdose. And that really probably suggested that was a group of folks where the synthetic opioids were somewhat endemic. And then another very elegant study from Massachusetts of 18,000 or so patients who had survived an opioid overdose and did not have cancer. And they looked at the enrollment in medications for opioid use disorder and other kinds of treatments afterwards. And there's a couple of related studies to this database that's helpful. What they found in this group is that about 11% of the patients started methadone for a median of about 5 months. About 1 out of 6 started buprenorphine, and they stayed on it for a median of 4 months. About 6% got Vivitrol, and they stayed on it for, on average, about 1 month, which is about 1 injection. And what they found is that the overall mortality was approaching 5%, and half of that was related to opioids. And what they also did was they did an analysis looking at mortality and whether they sort of, after their first overdose, whether they got methadone or buprenorphine. And as you can see, that getting on an opioid agonist therapy of either one of these markedly reduced all-cause and opioid-related mortality quite significantly, slightly more so with the methadone than for the buprenorphine. And when they looked across the other kinds of treatment options, there was no benefit for the patients who got extended release naltrexone. There was no benefit for those who got detoxing counseling. and then there was no benefit for those who got either short or long-term residential treatment with follow-up care, really suggesting that the work is being done by opioid agonist therapies. Now, one of the challenges for communities, and this is one of the things that seldom happens with a lot of engagement from the rural communities, is how to bring together a number of people to do collaborative learning. And whether you're looking at sort of, emergency medical services, the law, the police, et cetera, or, the emergency department, so the first responders, the prescribers themselves, each and every one of these sorts of constituencies brings together a slightly different perspective. Having people absent from the table can be a challenge. One of the things that has been sort of the overwhelming observation is that the rural settings are less likely to be sort of involved in this process, out of sight, out of mind. I sort of think of it in the same way that I think of the criminal justice system. But what happens in many of these collaborative learning environments is that they spend a huge amount of time on strategic planning, talking about putting this in place and that in place and all of these sorts of things and having all of these agreements. And to be honest with you, that's an important part of it, but it has really resulted in the consumption of huge amounts of money without much to show, because the epidemic of opioids is continuing despite all of this federal money going in. In fact, it is not improved in the last year, or last 8 or 9 months since COVID. There's a 43 out of the 50 states have got an increase in opioid related deaths. So, these types of strategies are not working. Where it is working, however, is where there is an active implementation process. So it's not just a strategic plan. In fact, I would say that strategic planning is the death knell for active implementation. So there are two very different strategies, and you can use collaborative learning for either one of them. The strategic planning is static. Active implementation is, I have an idea, we're going to try it, then we're going to adopt it, and then we're going to expand it. So there's a real science to doing that kind of work. Let me just move on to the issues to improve addiction treatment. Some of these touch points, I'm going to go through some examples and look at also the improvements of how to provide medications for opioid use disorder. This is from the same group, La Rochelle and Wakeman, that was from the Massachusetts Medicaid database, where they've just incredibly linked multiple sources of data. What they looked at was over 40,000 people who were identified or diagnosed with opioid use disorder based upon ICD-10 coding. And what they did was they looked at the trajectories. What happened to these people as they sort of left their first flight of overdose from an emergency department? And what you can see is that only 12%, that's sort of the national coverage, got on an opioid agonist therapy with methadone or buprenorphine. 8% got nothing. 15% got inpatient detox and then follow-up residential services. 5% got intensive behavioral counseling. And then what most people got, and this is in a setting where there's a lot of resources in terms of addiction treatment, 58% got non-intensive counseling and 2% got Vivitrol. And one of the things that I'm going to sort of make the point of is that most of these people got what we consider to be a non-evidence-based treatment. In fact, there are no data in any systematic review that suggests that these detoxes, either with inpatient or outpatient follow-up without medications or even Vivitrol itself, have any benefit for long-term consequences. But in this particular setting, you see that there is a great disconnect. I call it a round peg, square hole, or vice versa, where there is a disconnect between the types of treatment that people need versus what they get channeled into. And part of this has to do with the way that we triage patients, or the perception that people are weak if they don't get a methadone or buprenorphine. So that inner and outer context of how patients and providers perceive treatment, as if all treatment is created equally, is really a disservice that we're doing for our patients. And so if you just look at these patients who basically had an overdose or a serious hospitalization, at 3 and at 12 months, they found that being on methadone or buprenorphine reduced the likelihood that they would have an overdose, fatal or non-fatal. It also reduced the likelihood that they would have a serious hospitalization for, let's say, endocarditis or skin and soft tissue infections. And that was at 3 and at 12 months. Once again, all of these other treatments, the counseling, the inpatient detox, the Vivitrol, none of them had any benefit whatsoever in terms of reducing these really awful consequences of opioid use disorder. And what they did find, and they presented in Kaplan-Meier curves, was that the longer that they remained on an opioid agonist therapy, that is retention, it was associated with even lower reductions in these negative consequences for patients. So once again, what I want to say is that we need to make sure, whether we're in a rural or in a non-rural setting, we need to make sure that we put the patients into the right kind of treatment. And I think that it's really going to make and challenge us to come up with really interesting ways, which I'm going to sort of make an argument for, that we use telehealth and a number of organizations that are available nationally who will do this in the absence of having providers that are unwilling to do this. They will do this if a person's got Medicaid or any other kind of service, and they will get them on treatment, and they will get them on treatment immediately, which is unlike what's happening where we have this referral system where referrals seldom get a person into treatment. And in fact, more recently, systematic reviews looking at screening, brief interventions, and the referral part, the referral to treatment, does not result in markedly impressive outcomes. Now, I say that medications for opioid use disorder, and specifically opioid agonist therapies, are really effective from over 22 systematic reviews. They are superior to any psychological treatment, such as cognitive behavioral therapy, motivational interviewing, Narcotics Anonymous, and 12-step programs. That's not to say that these programs don't help in some ways. They might work for some small groups of patients who have really polysubstance use disorders or serious co-occurring disease, but it's not going to work for the overwhelming. And in fact, the supplemental counseling provides very little. And the reason why it does is because not everybody needs it. In other words, the workhorse in this is the medications. And I think that a stepped care program will probably with limited resources is going to be the way to go. We do know that patients who do get methadone relative to buprenorphine have generally higher retention levels. That was shown out in the study from Massachusetts. Unfortunately for rural populations, until the regulations for methadone change dramatically, that's not going to really be an option. I'm going to show you some data that dosing does matter. Putting patients on what I call homeopathic doses of medications for opioid use disorder does no one much good. And then we do know in head-to-head trials of buprenorphine versus naltrexone that buprenorphine treatment is superior with regard to reducing drug use and being retained in care and treatment relative to extended release naltrexone. But part of that difference is related to the fact that it's really an awful experience for patients to go through the detox that is required. And some of the detox protocols require that patients be extensively feeling sick during that time period, and they just relapse and they say, I'm out of here. And that makes sense. But for a person that you do get off of opioids, naltrexone can be an evidence-based practice. And in multiple systematic reviews and in a follow-up assessment of 3 clinical trials, the supplemental counseling does not improve addiction treatment outcomes, but that a brief 20-minute session that's given at the time of your prescription is equal to very intensive cognitive behavioral therapy or motivational interviewing. So we sort of, even though we may have legislative issues that constrain us, we might need to be thinking about that somewhat differently in terms of what we do and how we do it and for whom we provide it. I think patients who have a higher addiction severity might benefit from some of that, but it's not a one size fits all. And I think that if you're in a rural setting where you have limited resources, you really should sort of think about sort of preserving those intensive resources like an hour counseling session for those who are most likely to get something out of that. Now, there are multiple studies, but I'm going to show this one, which is a randomized controlled trial of patients who were detoxed over 6 days with buprenorphine versus put it on buprenorphine maintenance. And one of the things that you see here is that the relapse rate in remaining in treatment was essentially 100% within 2 months in the patients who got the detox. And this was intensive counseling. This is 1 to 2 hours a week. Unfortunately, because they were sort of detoxed, their tolerance was low. 1 out of 5 of the patients who got detox died from overdose. And so this is not an evidence-based practice, and that's been borne out in study after study after study, even in terms of empirical treatment. So the idea of referring someone to a detox, whether it's in residential or non-residential treatment, is probably not in the best interest of the patient unless you want to buy them a one-way ticket to heaven. The other thing that is important here is that whenever you're treating, wherever you are, that dose does matter. These are data that are published by Scott Farnham in our group, looking at the dose of methadone. This is retention over 3 years. So this is fairly impressive retention. And it's whether they are getting a therapeutic dose, that is, are the brain cells, the mu receptors in the brain being adequately covered? So dose does matter. And when you do a sub-analysis looking at doses of greater than or less than 12 milligrams, you find similar but not quite as exaggerated for buprenorphine. So buprenorphine probably still matters, but maybe not to the same extent that it does for methadone. Here's one of the places where anywhere, but especially in our rural settings, that we really have to rethink what we're doing. And the addiction treatment world has done this to themselves. And I do projects in probably 30 other countries around the globe. And I will say that the demand characteristics change from place to place. I work in Ukraine, where it's probably the most stringent, where you come 7 days a week, whether you like it or not, whether you're on methadone or buprenorphine. I also work in the UK, where they have pharmacists who do all of the addiction treatment. They use the physicians to diagnose, but all of the treatment happens, not all, but much of the treatment happens with pharmacists. And then we have other places where I work, like Malaysia, where you can get initiated and soon thereafter you can earn take homes. But the issues have to do with the demand characteristics that you put on patients. And this is going to be especially true for rural patients who oftentimes have to travel. They're expected to come back to get medications. They're given limited amounts of medications. So the first place where the demand characteristics get in the way of treatment is on access. So in other words, any place that has a waiting list, Johnny, you need to go to, this clinic. Johnny calls up the clinic and they say, we'll see you next week. That is not a response that works. Appointments and waiting for this is really an emergency. You saw the overdose related information. This is not something that we would wait on. If a person had diabetic ketoacidosis, we would not sort of say, I'll see you next week. So we need to sort of get rid of these waiting lists. And the outcomes are pretty clear that there is higher mortality where there is higher demand. That is where there's a longer or even a present waiting list. And I'm going to show you an example of what I call an open access sort of program that gets at some of this. If the admission criteria are inflexible, that is, they want you to do 15 things before you can get treatment. I can't treat you till I get your blood work, or these are all things that actually are not legislatively mandated. They say you have to have it, but you don't have to have it the first day. And the reason why I would say that it's important to rethink some of these, and I'm going to show you some examples, is that when a person is actively using opioids, they are seldom in a position to be able to adhere to appointments. They're seldom in a position to be able to go take care of 3 other things as they're going in. And when they're going through the process of just initiating treatment, they feel awful. And so let's take care of the awfulness first. Get the medication in their mouth, and then you move towards all of these other things. Oh, by the way, you need a physical exam. You need all of these other sorts of things. Physical exams, with rare occasion, make almost no difference whatsoever on outcomes. If your point of access is the specialty care setting, you have to go see the behavioral health person. That is a limitation and reduces access to care. But a regular clinic, you can just walk in, it's your federally qualified health center. Those are relatively low demands and on treatment that you can get. And then in places where you've got cost of treatment, there's been a sort of a proliferation of these for-profit places, less so in rural areas, but where if somebody happens to use for a couple of days, they go on a bender for the weekend and they're out of money, and all of a sudden they are no longer in treatment because the treatment program won't treat them, that is going to be a serious problem for patients. There are also some design issues around the treatment that are really challenging with regard to demand on patients. So where the treatment design is that everybody gets the same thing no matter what, there is no flexibility to how you do things, those patients are less likely to stay in treatment. If the medication options, do you have more than one kind of option? Can you float between them? Is there sort of a sense that, you know, that maybe perhaps that all medications are not sort of equal for every patient? Those kinds of places tend to do better. Ones that have limited treatment, they come in for, let's say, what they call a short-term detox. Really, that is sort of dangerous. Or the notion that a person's been in treatment for 6 months, it's now time. Many of these patients are going to need to be on it for a lifetime. And so we just are not good at predicting which ones. If they have relapse policies, and so in other words, if a person relapses or they use stimulants, those kinds of restrictions and kicking patients off will result in one, patients not entering because they know that there's a bad rap for it, or they won't stay in. And then where there is more structured administration around medications, there's this huge anxiety that if you give somebody a week's worth of buprenorphine, that you are going to basically flood the market. The data are pretty clear that buprenorphine diversion does happen, but it does not happen with majorly adverse and negative consequences. And I'll talk about that in just a few moments from a systematic review. And then the obligatory psychosocial counseling or treatment with that is a major impediment. As I said before, the data on that kind of treatment, you know, you want to give them 8 hours of treatment, not really much benefit to the patients. There's probably some benefit to reimbursement, but certainly it's a wallet biopsy for the patient in terms of the options around treatment, because most people, they want to get better, they want to go to work, they want to take care of their family, they want to do all of those sorts of things, but sticking with those other sorts of things may not get them where they need to be. Let me just show you some example of a sort of a high demand buprenorphine program. And these are data from West Virginia. We looked at data at 2018 and 2019. These are 2019 data. What you see here is that there is really the overwhelming majority of the prescriptions are only for 7 days. I'll show you some data during COVID where we move everybody out to 30 days or 28 days. The data actually are that they do better. All right. And so these kinds of restrictions, but look at the number of prescriptions that were given for a couple of days at a time, 25,000 out of these 3,001, and very few are getting at least a 28-day supply. It's the notion that patients don't behave. There are ways with telehealth, et cetera, where you can check in with people. They can even go to laboratories that are closer to them to get treatment, which is what we've done with a lot of our programs, and we can monitor them and to help them through that time period. One of the sort of models of sort of improving access and removing demands has been the use of the Niatex treatment improvement process. And it's been used mostly in behavioral health, but it's been used across a number of implementation changes. These are data over, it should be 7 years. And this is in a drug treatment program that had a long waiting list of maybe 4 weeks. They said, we don't have methadone slots for a while. And they increased their census from about 1,400 patients to over 4,000 patients. So 183% increased the number of patients. And it actually did not cost them one extra dime because they created efficiencies. What they did was this open access model posits with the notion that if you show up at the clinic before 11 o'clock in the morning, you will not leave here without getting dosed with medication. And they went from an average time of before getting dosed from 21 days to the time that they signed up to less than a day. That is a few hours, a half a day per day. what you look at whenever you sort of improve access to treatments, the things that people are very worried about legitimately, that there's going to be some negative consequences. So in other words, if you sort of make it, and by the way, at this particular program, they got a day off from methadone on Sunday every day. That's allowed, but most places don't do it. The retention on treatment was no different before and during the process, so it remained about the same. The use of other substances and opioids was not increased in any way. And what you worry about is if people have got more medication and is out on the free market, is there an increase in mortality? And there was not across the board. And so this is really a proof of concept that if you change what you do and make it more flexible and remove some of the demands, that patients will actually do better. Here's an example of one of the change projects, this implementation change project that we did with Niatox. This was in a country where a person would make a decision to get on to treatment. They would require them to prove that they were really serious about this, and they would have to get detoxed twice. I've got news for you. Anybody who's gone through detox once will certainly not want to go through it a second time. And this is in a place where the coverage is about 2.9%. So it's almost what I call a bureaucratic impossibility. They'd have to come back to the clinic, and then they would send them out on their merry way to go get a physical exam, to go get screened for tuberculosis, and to get a laboratory assessment. In the meantime, they have to maintain their drug habit during all of that. I shouldn't use the word habit, their opioid use during that time period. Then they'd have to come back to the clinic with all of these accomplishments, and only then could they be put on treatment. Now, what happens if you change the way that you do things? In other words, you restructure it by looking at it through the lens of the patient. So this is a program with very high demand characteristics. And we ended up sort of changing this and said, all right, this detox probably isn't necessary. In fact, it's bad for business. Coming back to the clinic multiple times is bad for business. Having these required screenings are also sort of bad for business and bad for patients. Let's move them, because there is sort of a federal requirement that the patients have all of these things done, but within 2 weeks of initiating treatment is sufficient. So you basically bring them in, you make sure that they have an opioid use disorder and meet criteria for methadone. You put them on a dose that day, you get all of these other sorts of things done while they're feeling better. They get stabilized, and you move them to take home dosing fairly quickly. So this is what I call a rearrangement to remove the demands. And part of what Niatox does is it sort of helps you understand what it looks like from the patient's perspective, as opposed to the way that we like it to look from a clinical perspective. We do a number of things in medicine that is convenient for the clinicians. When you deliver a baby, you ask a woman to sort of lie on her back and push without any benefit from gravity. But we know from the evidence that that's not very good for the baby, and it's not very good for the mother. She should be squatting, and ideally in water. But that's not what we do. That's not convenient for the clinician to actually squat down and help through that whole process. So this is once again one of those sorts of it's an engineering exercise of restructuring the order in which we do things. Here's another change project that we're sort of working on with emergency departments. And so this is, we're trying to do some work earlier on, but here's an example is that that if a person comes into an emergency department, they're either going to be admitted to the hospital or they're going to be, released home or to the community, or maybe to treatment. And we took some availability of whatever the resources were here, and we sort of went through some, what gets in the way of treatment from starting it in the emergency department. This is the funnel. If you basically assess them and send them to the emergency room, if you've got 15 hospitalists at your hospital, each of them has a different attitude. That's going to be a challenge. However, if you have an emergency department that's committed to it, you induce them while they're sitting in the emergency room and get them up if they need to go to the hospital and write the orders to maintain them. By the time the hospitalist sees the patient feels much, much better, and they're less likely to continue it. And you can add a consult to that if you'd like. And then you can walk them through the whole process of making sure that they get really good care. The alternative is they have an overdose, or they come in with a skin and soft tissue infection and you give them antibiotics and you release them. Well, if you happen to have recovery coaches in the community, they can work with them to help link them. But if you do the workup in the emergency room, the physical exam, which counts as part of the requirement, if you do the blood work that is required and you diagnose them and given them treatment in the emergency room, then it basically makes it so that a person doesn't have to go through a reassessment. They can go back to the outside. Now, let me just tell you that you need to sort of develop a coalition of community providers. And some of this, the network stuff that we've done in Vermont is that we have created, let's say, 5 different providers, and provider A takes a person who gets released on a Monday and provider B on a Tuesday, et cetera. And you can come up with a system where when a person gets released from the emergency room, they can just go straight to that place and they can continue to get their treatment. Now, they have changed their policies a bit, so a person in the emergency department can get up to a week's supply, but we've not been able to get beyond that legislation in every single state that we've been working. But this is a rubric. It's really doing flow charting to sort of look at what it looks like from the patient perspective and what do you need to get in place to make it happen. And you need to sort of monitor this in real time. Let me just talk a little bit about, oh, by the way, I want to point out that let's say you happen to be in a rural setting and a person goes out. There are these organizations that are national. You may not have the infrastructure within your state, but I'm going to come back to the Spoken Hub model in a few moments. But you can have these telehealth programs where you set them up in the emergency room, you do all the blood work while they're there, and you'll say, all right, talk to Brightheart. They get a counselor on, and within a few hours, you have a prescription for opioids because all of the basic work has been done right there. So this is, once again, a great model for rural communities. We've learned a lot about what to do during COVID. This is a paper that just got published today, looking at what was happening in 26 different states or oblasts in Ukraine. And what they did was they got interim guidance almost the same day that we did here in the US to sort of transfer as many patients as you safely can to take home dosing anywhere between 3 days and 10 days, depending on how stable the patient was. And as you can see, there was a marked increase from about 50+% to 80+% in the patients who moved to take homes. Now, what this did was this translated, and this is in a country that has mostly non-take home dosing. It's supervised therapy. What you can see that happens, most people got moved to every 10-day dosing. And the difference, if you were to continue that over a year, and given where COVID is going, I think we're going to get there, but that reduced the number of contacts between clinicians and patients by over 1 million for the number of patients in the country and that are on therapy. And that reduces the workload by about 85,000 hours. What these clinicians did was they switched over to telehealth to take care of patients all over the place. The patients actually were better retained on treatment. And you worry about whether or not giving them all of these take-home doses of mostly methadone would result in a higher, sort of overdose-related mortality. And indeed, it did not. It stayed about 4 to 5%. There's been no change whatsoever. And we've just updated this information, really suggesting that removing the demand. But let me show you what it did do. All right. So what it did was these patients went to more telehealth. They have check-ins by the providers. It reduced the demand on patients, and the dropout in green steadily decreased. So it had elevated during the first quarter of the year, and then it went right back down during what I call the post-COVID time period. And during this time, they managed to sort of move to a tele-educational program. Now, one of the limitations that they have, similar to what we have here, is that for methadone, they require a physical exam, but they also require it for buprenorphine. So they would have to see them once. But here in the US, we have very similar data from our treatment programs with buprenorphine that show that you can increase the number of patients. You never have to see them physically. They do really, really well, and they're getting minimal to no counseling. I will say that if somebody screens in on the teleconference of having a psychiatric disorder, I'm going to be much, much more inclined to push in that direction during that time period. And I'm giving them sort of substantial doses right from the beginning. The idea of giving them a dose is, and then having them come back is not useful. And in fact, we have an app that we developed that anybody is welcome to. It's a home induction app where they just take this app and we get them up on to 12 milligrams by the first day, 16 the second day, and they do very, very well. Most of our patients have had it in one way or the other in the past or through friends in order to get them through a rough weekend. And so they know how to do this. And so it's not rocket science at this point. Now, the biggest concern that people have had during, all of this sort of relaxing of the regulations is that we're going to have a huge amounts of diversion. There is diversion that's going to happen. In all of the big studies in the US, it's been around on average about 20+% that happens. They're not really so much doing it for nefarious reasons. Some of them, of course, are selling it. There's going to always be a subset of that. But they're oftentimes, the most common is that they're sharing it with other people to help them out through a rough edge because the other person does not have the flexibility to go through the whole process. So almost all of this diversion is helping a friend. There's going to be some that's going to be for sales for sure. This diversion very rarely results in injection, 1 to 3%. So they're not sort of diverting and then, injecting it. That's not the route by which it's doing. It's usually for treating someone. And if they're getting the combination of buprenorphine with naloxone, that's markedly less with regard to injection because it does precipitate withdrawal. And even when they do, you could probably put a handful of buprenorphine tabs under your tongue and yeah, you would have a headache and you'd have some nausea and vomiting, but you're not going to overdose with that. Where you get into trouble is whenever they're using barbiturates, I'm sorry, not barbiturates, but benzodiazepines in excessive doses. And, one of the things that I often say is that when I do know that there's buprenorphine or I learn diversion and I learn about it, I use it as an opportunity to say, hey, bring your friend in, we'll take care of them too. So it becomes a sort of an opportunity through network. So how do we scale up treatment in a number of different settings? There's a sort of a hub model, which is where you got the uber experts, and those are the people who can do the inductions, although I have to say it's not that hard to do that. You can do high volume scale up where it's all done centrally. So you have the expertise. In Vermont, you might have a centralized place that does a lot of this stuff. And then you've got a spoken hub sort of model where you've got these other places, these federally qualified health centers, smaller treatment programs, private offices that provide the treatment. I think that we really have got to sort of arm up primary care. I started doing my HIV work 35 years ago. Probably 30 years ago, the medications were so toxic and it was so difficult. And I talked about how complex my job was. It's easy. It's one pill a day and, it's not rocket science. The same is true for methadone and buprenorphine. It's gotten pretty darn easy. This is not rocket science, but there is a sort of a stigma and discrimination, how you're perceived by your peers if you do this, and how it is, how you perceive the types of patients that you might take care of. We might need to think, at least in rural settings, about how pharmacies can do some of the monitoring. There's a few places that have started some of this. So one of these pilot projects would be certainly worth sort of looking at, where patients go to sort of standardized blood phlebotomy stations and get their blood work drawn, and the pharmacist can use that in order to help sort of guide some of the therapy. And then of course, there is always the last frontier, which is our criminal justice setting. Let me sort of move to that. Every person with opioid use disorder should not leave prison or jail without overdose prevention with naloxone, nor should they leave without being on medications for opioid use disorder. There has been a huge push to use Vivitrol, which the data are just not supportive in terms of improving health outcomes. It probably does protect them from overdose for a month, and that is certainly the riskiest zone. So I would say that there is some benefit to doing that, but any Vivitrol injection at transition should be linked to somehow getting onto medications after release. So first of all, it is just dangerous to incarcerate people with opioid use disorder. They often go into withdrawal. They go in, they are not treated for medications. And if you release them, or when you release them, because almost everybody gets released, they have an extraordinary level of likelihood of overdose afterwards. And if you compare the time periods for overdose in the first couple of weeks versus the weeks 3 to 12, so the first 2 weeks versus the next 10, the likelihood of dying after leaving prison is somewhere in the 4 to 8 range, increased likelihood. And these are mostly in high income settings, but there's very good data from the US, Washington State, and especially New Mexico. A lot of that is in somewhat rural settings. And you can see some of the data with regard to overdose. So the question is, they're leaving prison, they're leaving jail, they're not tolerant, and they're used to using, let's say, a bundle of heroin or even 2 or 3 bags. That's just too much for them. And they don't have the kits, and so that's a problem. What happens is that there has been sort of this long-standing belief that people who are in a controlled setting and who are not using drugs are treated of their opioid use disorder. Here is a study that we did looking at people who were in a controlled setting for 2 years, and they had weekly urine tests. So we knew that they were, for the most part, not using drugs in that setting. And we compared it to patients who got methadone, and we looked at them over a year. And what you can see is that the biggest amount of, well, the first thing is relapse was 90+% in the patients who did not get a medication for opioid use disorder. And it was about 36% in the patients who got methadone. And in this case, the dose mattered. Higher doses of greater than 80 milligrams were significantly more likely than lower doses. It was more along the lines of 80 versus 30% who would be free of opioids. And then, of course, one has to use opioids before you can have overdose. But once again, we're getting at that time point of vulnerability when people relapse, which is certainly within the first month, but the biggest drop happening in the first couple of weeks. So these data are not any different than what we saw from the systematic review by Merrill and others. And if you wanted to use things like Vivitrol or buprenorphine injection, this might be a good place to do this, but you still have to have sort of a transition and a linkage to treatment thereafter, because you need to sort of maintain patience. Here's a study that we did looking at prisons and not just opioid overdose, but some of the negative consequences, the third arm of this. And what we did was we modeled a couple of different scenarios. We looked at the full projection, where you would sort of remove all of the risk of incarceration for people who inject drugs. It reduced the likelihood, but not significantly, to about 12.8% infections. You could reduce the infections by about 20% if you would scale up medications for opioid use disorder. But the key thing is that if you did not sort of make sure that they got retained, that is, you treated them during incarceration, but did not maintain them afterwards, that sort of benefit was significantly better, but not nearly as good, about 1/4 of the benefit that you would see. And part of the reason for that is when people are released from prison or jail and they're not tolerant and they do relapse, they also relapse with people that they don't know. They don't know whether they're give them fentanyl. They don't know their HIV status or their hepatitis C status. So their risk of getting HIV infected is 4 times greater during that first year after release, because their social networks are somewhat distrusted. We took data from this particular modeling study that examined this in one specific area. And we said, all right, let's look at it across 3 different parts of the world. And the reason why I ask you to look at the Kentucky data is that the Kentucky data is a place that is primarily rural. And so there are 4 different settings in this particular study. We've got the status quo, what would happen with regard to death. So this is death, not HIV infections. If you just did what you did with the differing levels of coverage in these different places in the country. Kentucky, there was almost none. And in Ukraine, it was about 5%. And in Tehran, national coverage was about 11%. The scenario would be just to scale up opioid agonist therapies from those numbers to 40%. And you would get, basically some reduction. So it's an incremental reduction. But if you actually improve the retention, that is, you gave them the right dose of medications and kept them on for at least 2 years, we know the longer you're in treatment, the better you're going to do. You would have a majorly twofold increased benefit, whether it was rural or otherwise. But if you scaled up opioid agonist therapies in prison and maintain them after release, you get the most bang for your buck in that particular setting. And so it really speaks to the important role of people who inject drugs, who go in and out of our carceral settings, as a way to sort of engage them. And I would even say, if you scaled it up in the community, you would be more likely to even reduce incarceration in general, and you would have to do less of that. But unfortunately, we are far from the kind of coverage levels that you see in Western Europe that are 40 to 60% coverage. Nationally, we're 11%. Here's a change project that we've been working on in prisons and jails. This is what you would do at jail intake. You would actually screen them for recent opioid use, and then you would sort of see if they're in withdrawal. And one of the challenges that some of the places are having is that the access to methadone immediately is a little bit delayed. It may take several days to go through the process to get the eligibility. So you could start them on buprenorphine immediately, and then you could switch them to methadone whenever you got all of the paperwork finished. And so some of the legislative requirements make it so that that might be the model. If they're on whichever medication for opioid use disorder, you would continue it from the time of coming in. And then the key thing is that as they release to the community, it's the same sort of structure that I talked about with regard to emergency departments. And that is, you need to have a network of providers who are going to be able to see them. And you need to have a way to communicate that information. And you need to get some kind of agreement so that, let's say, Site A is going to take Monday releases, because what you don't want them to do is you don't want them to have to wait for an appointment. So they need to be able to get it. You can do this with telehealth. So in some of the places that don't have that kind of agreement, you can do that with telehealth as they transition in. So Bright Heart is one of these national organizations. There's a couple of them, but they will take these referrals and they will do all of this for you for stem to stern if you don't have the rural infrastructure that you need in order to manage patients. So this is going to be sort of our heuristic to be able to sort of scale it up in every place that you can imagine in patients. And I will say that sort of moving into these spoken hub models in rural settings seems to be the model that has the most traction. The work that we've been doing with Vermont really sort of has an outpatient behavioral health service that serves as the hub. And then there's a number of different places, departments of correction, family health centers, federally qualified health centers, all of these other sorts of places that will actually either start or they will take the referrals, and it can go in both ways if patients are just too sick to be maintained. So you have to have sort of those agreements. And their coverage level and their reduction in opioids, I mean, it certainly has not gotten worse like most of the rest of the country. So I think that there must be something that they're doing right there that has not succeeded. This is happening in other places. Colorado's got an excellent program and a number of others. So these are all modeled over a couple of different programs. But in rural settings where you don't have the infrastructure to accomplish what you'd like to be able to do is a sort of a good model. So I would just say in summary, these rural epidemics require rethinking, and the lessons from COVID and telehealth and all these sorts of things are useful. The lack of resources, I think, does require a transition to telehealth, even for sort of these national providers. I think in most rural settings, a hub and spoke is more likely to have traction, but you will need to engage the various different stakeholders. And then as it relates to prisons and jails, we need a continuous way of thinking about opioid use disorder as a chronic and relapsing condition. This isn't something that you treat this week and not treat the next. We really need to get it into a hypertension or a diabetes model where in the absence of treatment, patients do poorly. Thank you very much.
Rick, thank you for a fantastic presentation. That was really terrific. We are a little bit over time.
Oh,
We have a
so
couple
sorry.
of questions. No. And I'm just wondering if we email those to you, would you, there are just a couple, answer them, and we'll post them when we post the video that's been recorded and it'll be available.
Okay.
Is that acceptable?
Totally happy to do that. I'm sorry I ran over.
No, I'm glad you ran over. It was fabulous. And I think it really sort of, brings into question, we need to really change the paradigm, change how we think, use telehealth. I mean, I think you're exactly right.
Yeah, I mean, the problem is that, we responded rapidly and urgently to COVID. We've got the same epidemic that's going on in parallel, and we have not done that. We have killed ourselves with strategic planning, and we just haven't done the hard work that we need to.
In our hepatitis C clinic, and it's one of our terrific infectious disease nurses, with telehealth, the appointment adherence went way up. I mean, multiple fold. It's clear. Anyway, let us move on. Thank you so much.
Pleasure. Thanks so much.
Very well, and thanks to all of you for listening.